Hi, everyone. Look, before we start, I'll just say Terence has been telling me that I have to really speak up because it's quite quiet. So if you are having difficulty hearing me, if you could just speak up and say, that would be fantastic, because if I get carried away and I'm looking down, then I might get a bit soft.
Sorry, Jackie. Attendees aren't able to speak, but they are able to type. So I'll let you know if they say anything.
Cool. All right. Thank you. Okay. So what I'm going to do is just take you on a little tour of STIs from a public health perspective, so that you know who I am, because you might think, well, what's the director of an AMS got to do with doing public health or sexual health? But in fact, I do have qualifications in both of those. I was made a public health doctor about more years ago than I care to remember. It's probably about 12 now. And before that, I was a sexual health physician for quite some time. So what I'm going to do is just go over what I aim to cover in this session. And I understand we've got until 2 o'clock. So please let me know if you've got questions. Terence sounds as though he's going to be storing them, and we'll get to those at the end, if that's okay, if you guys can't talk and interrupt me. So the first thing is have a think about why it's important to control STIs, and then outline and have a think about some of the reasons why we haven't achieved that particularly well, and then have a look at some effective interventions. Then I'm also going to touch on the role of screening and look at how you actually assess STI tests and good screening tests. So there's a bit of sort of straight public health theory in this as well. And I'm also going to touch on the value of point of care testing as well. So we're going to be talking about that. And then finally, we're going to finish off with trying to make sure that people can effectively and competently list components of effective STI control programs, if that's one of the questions that you get in your OSCE. So I'm going to take you on a little journey now up to my neck of the woods, which is Cairns, which I've renamed Campbellonia. So there are plenty of exciting things here, but there's also quite a lot of STIs. Now, the first thing we're going to cover is why STIs are important, and then I'm going to talk to you about the Anderson and May equation. Now, I never really got the Anderson and May equation until I was made to use it. And for those of you who like letters and words rather than numbers, we'll go through what that series of hieroglyphs actually means. And then we're going to look at factors responsible for high rates and interventions. So it's your first day as a public health doctor sitting in far north Queensland, and your new CEO comes to you and says, chlamydia is really, really high here. We've just got some data showing that we've got the highest rates in the country. You need to fix it by Christmas. You've got 9 months, and my position's up for review at the end of the year, and I would like you to fix it before that time. So let's have a think about what things are important in terms of STIs. So there's a couple of different things. The first is that they carry significant morbidity and mortality as far as reproduction is concerned. They are also responsible for a number of cancers, and they are enablers of HIV transmission and acquisition. So there's huge issues as far as that's concerned, particularly in my neck of the woods where I'm in far north Queensland. We know in Papua New Guinea there is a heap of HIV across the border, and a lot of the Torres Strait Islanders are within spitting distance of the PNG border. So just to put a bit of context in terms of the prevalence of STIs, or incidence if you like, and we can talk a little about that at the end if we have time, about why I've said prevalence, because prevalence is usually something that you talk about with a chronic disease, but because the rates have been high for so long, I think it's actually a reasonable title to use for this particular issue. So we have 80,000 cases of chlamydia and gonorrhea in Australia each year. Although it is plateauing in the general population, it's still increasing in Aboriginal and Torres Strait Islanders, and there's a few reasons for that which we'll go into. This is a huge issue, as you can see, because it's it's much higher in younger age groups who are obviously more sexually active, and there are high rates of co-infection. STIs tend to travel in packs. Fortunately, I'm touching some wood here, the prevalence of HIV is fairly low, but we do know that there are pockets of infection, particularly in the much more high-risk populations. And there's certainly an outbreak at the moment amongst people who are teenage and homeless in Cairns, which is a real concern. Now, this actually comes from, this is data from the Kirby Institute, and the stuff I've been quoting from is also from the Kirby. So they produce an annual report, which is fantastic. So if you want to know anything about STI epidemiology, that's where you head to. And they've got a special section that is on Aboriginal and Torres Strait Islander epidemiology as well, which is really useful when you're writing grants for funding or whatever. And so, yeah, it's something that I refer to quite a lot. The other thing is, this is probably, well, may not be the time to do a little ad, but this is the new preventive guideline for preventive health assessments for Aboriginal and Torres Strait Islander people, and most of the figures about STIs came from the Kirby Institute for that particular chapter. Now, as you probably know, chlamydia is a sexually transmitted infection caused by a bug called Chlamydia trachomatis. Most notifications are in young people, and there was this fairly large meta-analysis that was done by Lewis in 2012, and he looked at 67 studies, which are shown in the graph combined. The prevalence can be seen on that vertical axis, and the different populations are along the bottom. So if you have a look in the general population, it's only 5%. In young Indigenous women, it's 22%. So in other words, more than 1 in 5, almost a quarter of Indigenous women under that age have had chlamydia. Then it's 14.6% of Indigenous young men who are also under 25. And then in men who have sex with men, it's roughly the same as the general population. Okay, so what is the reproductive morbidity plus or minus mortality in rare instances? The first is pelvic inflammatory disease, obviously untreated chlamydia, and sometimes multiply treated chlamydia or gonorrhea can lead to infertility if you've got blockage of the tubes. If it leads to scarring and partial blockage of the tube, that's when you're at risk of ectopic pregnancy. But it can also have an impact on male fertility as well with epididymitis, again, with blockage and scarring of the vas deferens. Bacterial vaginosis and trichomonas do not ascend in the female genital tract, but they certainly do cause some issues with premature rupture of membranes in pregnant women. And of course, there are neonatal infections, gonococcal eye disease, chlamydial infection, pharyngeal warts, which I have to say are very rare, fortunately. Syphilis is a big issue, and it's a particularly big issue in Cairns at the moment because in the last 6 months, we've had 2 congenital deaths, which is a real tragedy because that's a preventive waste of life. One was in Townsville and one was in Cairns. So that's something that really shouldn't happen in this day and age. And then if you look at the cancers, hepatoma from chronic hep B, cervical and anal cancers with HPV, and lymphomas with HIV. This is a primer on how you successfully transmit or get HIV. If you want to get yourself gonorrhea, then you have a 3.5 increase. If you have an open chancre, which is the primary stage of syphilis, you have a 5-fold increase, which kind of makes sense when you think about it because there's a breach of mucous membranes or skin, and there's a whole lot of macrophages and white cells sitting in the base of that because it's an inflammatory process, and they're sitting ducts to get HIV infection. Even chlamydia, which isn't that inflammatory, is a 2-fold increase, and trichomonas is a 1.3. I have seen some really interesting papers actually looking at Africa where there is a lot of trichomonas, and there's also a lot of HIV, and they're saying that given the sheer numbers of people with trichomonas, it's a much bigger threat in terms of HIV transmission and acquisition than gonorrhea is. Okay, and I guess the other thing is that co-infections will increase HIV mortality. All right, let's move on to the fun mathematical part of this presentation. R0 is said to be the reproductive rate. In other words, are STI rates increasing? In other words, is it greater than 1? Is it staying the same? Is it stable? So it is definitely a prevalence rather than an incidence, and that's equal to 1. Or is it decreasing? And these fellas worked out of Oxford quite some years ago now, but they did some pretty amazing work. And they basically said that as long as you take into account a couple of key provisos about the population you're interested in, and they are kind of, this is where the theory kind of comes into it, because one of them is that you have a stable population with no influx or efflux. And really in Australia, unless you're looking at the entire Australian population, and even now with comings and goings, that really doesn't make any sense. So it's helpful to consider this in terms of what prolongs the prevalence of a STI in a population, but given that we're never ever going to be a kind of island unto ourselves, we're always going to have to take this with a kind of a fudge factor, if you like, and it isn't actually going to equal, it's going to be equivalent to. So there are 3 factors that we need to take into account. The first one is the intrinsic infectivity of whatever STI you're looking at. And in fact, these can be applied to any kind of infection if you like. It doesn't have to be an STI. The next one is C, which is the rate of partner change. So in other words, the more partners you have, the more likely you are to pass it on, and the more likely you are to make sure that there are a heap of other people infected before they get treated. And then the bottom one is the interesting one, and that's the duration of infectivity. And we'll talk quite a lot more about that in a sec. So if you think first of all about the reasons for high rates, there's a chance then to think about what kind of interventions you might have just given those reasons. So we're going to consider the B and the kappa first, so the intrinsic infectivity of the organism. As you can imagine, there really isn't an awful lot that you can do about that. Way back in the early days, this was in the 90s, there was some experimentation with gonococcal mutated strains that were less infective, because gonorrhea is very highly infective. But really, just given the fact that if it was less effective, it probably wouldn't take root in a population, I think that as a control strategy is kind of dead in the water before it even starts. In terms of rate of partner change, you could use condoms, for example, as a possibility of saying, well, that's the partial answer to that. In other words, if you always have protected sex 100% of the time, even if you did have 50 partners in the last 6 months, that really doesn't mean effectively that you're going to be able to pass it on. So that's part of it. And also, I guess the other thing in terms of education, and this has certainly been used with some success in Africa, is education of people, saying, you know, you don't have to go and have sex when you're 14 or 15. What they're trying to do now is prolong the age at first coitarchy, in other words, the age of first sex, as a kind of control strategy for STIs, and more importantly in Africa, HIV. So as you can see, there's a couple of things that you can do there, but really overall, in terms of intrinsic infectivity, your control strategies are going to be pretty limited. So rate of partner change is going to be dependent on youth, people who think they're 6 foot tall and bulletproof, and so they're not going to use condoms because they don't want to. Multiple different partners, early onset coitarchy, which is what we've said. And the other really important thing, I think, is reinfection by a non-treated partner. And so if you actually look at the kind of control strategies, which are people-friendly and also service-friendly, one of the really important things is making sure that you get people tested again at the 3-month mark. And the important thing there is that you're looking for that reinfection by somebody who wasn't treated, that perhaps they were too ashamed to talk to you about to start with in terms of their contacts. The other interventions, so we talked about them: condoms, education, treatment guides, and rescreening at 3 months. So I quite like this slide because it really brings home the fact that you can't tell who has an STI by looking or by their name. But the other thing is you can't also know that you've got an STI unless you have screening, because so many of them are asymptomatic. And that's part of the issue that has meant that for a long time now, our STI rates have been uncontrolled. Okay, so the next thing I'm going to look at is duration of infectivity, which is quite exciting because there has been some recent kind of progress in these areas. So we're going to look at population factors, access to treatment, tests and treatment. So population factors. As we've already talked about, populations are highly mobile. There are high rates of infection in the existing population. Certainly here in far north Queensland there are. So that means that in the socio-demographic space that you tend to have sex in, there is a higher likelihood that you will get an infected partner if your prevalence locally is high. There's also low awareness and low sort of want to know about STIs, and that's really, it was brought home to me a couple of weeks ago when I saw a young fella in clinic who wouldn't let me examine him, which was very frustrating because he was talking to me about some horrible things that he was worried about that would make his willy drop off. And in fact, in the end, it turned out that he had syphilis. There's also pretty low health-seeking behaviour, unless, as you said, as I've already said, you're worried that your willy's going to drop off. And also there's asymptomatic infection. So people, if they're not aware that they've got an issue, will not come and seek treatment. So what can you do about this? You can increase awareness of local STI rates and complications, but as I've said, that is not an easy thing to do. One of the things we're going to do in May in our health service here is implement STI testing month, which is trying to just lift awareness and trying to make sure that people are thinking about STIs when people under the age of 40 walk through the door for whatever reason they come into the health service. You can promote easy, appropriate treatment services. And one thing that we are looking at more is looking at out-of-clinic testing and treatment options. The other thing you can do is look at community condom availability. Now, I did some of my public health training in the Kimberley where we had these things called condom trees. And so basically they're looked after by the environmental health department. They weren't looked after by health, and they were basically just restocked every week or every month, depending on how popular they were. And these were scattered all over the Kimberley. Interestingly enough, one of the things that made them so successful was actually sending out, and they're just made of plain PVC pipe, a little bit like a kind of bird's nest, if you like. Some of them, like the one on the left-hand side that you can see, were sent to local art groups and said, you know, righto, make a beautiful design on it and then we can hang it in the community. So it really sort of promoted awareness and buy-in. So I think that was actually a pretty good thing. The lovely thing about this is that it's 24-hour access. When we implemented this across the Kimberley, and this was quite a few years ago, the only council that objected was Kununurra, and they were worried about, you know, kids getting hold of condoms and making balloons out of them and lots more wastage and stuff in the community. But in fact, when they were implemented in all of the other shires, that didn't happen. So let's have a look at some service factors. First of all, if you have a gender appropriate healthcare worker who's going to be non-judgmental and offer screening, you're much more likely to be able to pick up these asymptomatic diseases. It'll help also, particularly given the kinds of people that will get STIs, if you have a patient-friendly service, if you incorporate STIs into a general health check, and you make sure that they are simple to read, service-friendly guidelines, and that staff are educated in implementing them. This is a health worker I worked with up at Mossman Gorge who was fabulous. She was totally fearless in talking to people about STIs. Not everybody is like this, and so when you find somebody like this, or you know, if you try and be one yourself, I think it's just like gold. Now, the next thing I want to talk to you about briefly is a research project that I was lucky enough to be involved in a couple of years ago, which is called Strive. Again, this was an initiative from the Kirby Institute, and it was basically to look at whether a quality improvement program can really help achieve or exceed best practice targets in sexual health service to people. And if you do that, does it actually reduce community prevalence? Now, this took longer than anyone else thought that, to publish, but I understand it was published last year. So what they looked at basically was prevalence of chlamydia, gonorrhea, trich in 16 to 34-year-olds, and they looked at coverage, time to treatment, whether people got a 3-month test after a reinfection, and whether people got contact traced. And then other things that they looked at was barriers and motivators related to the uptake of STI clinical services, whether people were successfully managing and diagnosing PID, and the field effectiveness, if you like, of this, because this was actually trialled in fairly remote places, just to see whether outside of a trial context, whether this kind of intervention was going to be doable. If you look at the duration of infection, the other thing that might have might make a difference is testing factors. So the acceptability of a swab, for example, versus a urine. These days, this argument really doesn't hold water, because most people are happy to pop to a toilet and in the privacy of the toilet produce you a urine specimen. I did have somebody who was so frightened about the test that they came back with a urine pot filled with water. But most of the time you will get urine, whereas you may not get an examination, as I've already said to you, and you certainly may not get a swab from a bloke, because it's quite painful if you're going to do a urethral test. The turnaround for results, particularly in remote places, is a huge issue. Not so much for Cairns, but certainly for Cape York, where the average turnaround for tests was up to 3 weeks. They were in the bad old days when, and the Cape still actually uses paper records, so they still have paper results for the pathology company. And that means that for 3 weeks, people are walking around having sex, making sure that these STIs get spread, when really, if you're going to get a turnaround that's far more rapid, you can really make a huge difference in terms of complications, but also in terms of prevalence. The test has to be reliable. It has to, the acid test that people talked about in Alice Springs was that if a pot of urine could sit on the dashboard of a ute for 2 days as it was driven into the hospital to get tested, then that was durable enough. But it also has to be accurate. We're going to talk about screening tests in a second. And then once you have a positive test, you need an effective management response. So a recall, a test for other STIs if that hasn't already occurred, and effective treatment. Also means education, condoms, partner notification, and a retest. So what can you do in terms of testing interventions? The first is that the urine PCR test has really revolutionised this. Although in the centre of Australia there were some issues with PCR which were about interference within urine specimens, it does actually stand up to the 48 hours in a ute test, so it is incredibly robust. It's private and reasonably painless as well. The Tango trial, so if you remember nothing else from this talk, remember Strive and Tango, because they have been 2 landmark trials in terms of STI prevention and control in the Australian context. Looked at the use of point of care testing, and we're going to go over that in a sec. Then you need service-friendly guidelines: recall, educate, condoms, partner notification. If you look at effective treatment, the first thing is it an acceptable treatment? And most STI treatments now are single dose. Because of the increase in gonorrhea resistance recently, it has meant that the first line of treatment for most jurisdictions now is a needle of ceftriaxone, which is quite painful. So if you've got needle phobic people, you might be in trouble. However, most of the time, if you talk about why it's important to treat STIs, most people will say yes. You need the appropriate choice, so you need an informed service organisations who know what they're doing in terms of selecting the right antibiotic. Sometimes watching people take their tablets or giving them their injection can really help, because then you know that they've actually been treated. Resistance, as I've said, is an increasing issue, and then complicated infection may require different treatment. And you also need to think about treating contacts. So I will just say one thing about resistance. As I said, it's regional specific, and we try and use the WHO criteria to change treatment. I'm going to show my age now and talk about John Tapsall, who was a giant in terms of, he was a microbiologist who was based in Sydney and who was very interested in the gonococcus. And he did some really landmark studies showing that you really do need to change treatment once there's more than 5% resistance in any given bug, particularly gonorrhea, because it was capable of transforming very quickly because of its capsular surface. I guess the other really important thing is, and it's a no-brainer, but we'll go through the maths of why it's important. You need to treat the patient and the contacts as quickly as you can to prevent that transmission. So, more generally, STI strategies need to include interventions that are targeted at the at-risk population, vaccines, which I'm not really going to cover here, but certainly have made a huge difference to hepatitis B, for example. Implementing a syndromic approach to management can really help, particularly in areas where you do have that very slow turnaround for pathology testing. So, for example, in very remote places, actually, if someone does come in with a pussy urethral discharge, then treating them first and then asking questions and getting the pathology test back later can often really help. Contact tracing is also really important. Usually people will contact trace back at least 6 months, just depending on the infection that you're talking about. Behaviour change is much more problematic, particularly for younger people. However, trying to implement the use of condoms a bit more consistently really does help. And for that reason, actually having clinical staff who are happy to put a condom on a banana and show people how to use it, so that they're trying to do it the first time with the lights on in a place where they can see, and they can have a think about, you know, which way up the condom needs to be before they're fumbling for it in the dark and, you know, ripping it without knowing. So I'm just going to move on to screening now and having a look at conditions that are suitable for screening. So this is more like, well, it is as it applies to STI screening, but I'm going to use a couple of other examples. So with a decent screening program, there are a couple of things that you need to think about. The first is the cost of the screening program. The next is, do you have an acceptable test that people are going to be happy to use? So for example, urethral swab, no. Urine test, yes. Asymptomatic versus non-specific symptoms in early in disease. So STIs certainly fit that criteria. Is there a reliable, safe screening test available? We've talked about PCR, and yes, that's definitely true. And then the next question is the kind of million-dollar one that is really important. If I can, I'm going to just tell you a very quick story about a nurse that I met once who had been working in one of the Pacific Islands, and she'd gotten there from Australia and was horrified to see that there was no, what would be called then pap smear screening implemented in this particular island. So she embarked on a campaign and she got everybody with a pap smear, and then she found a lab that would process them. But then she found that there was nowhere where you could actually get a colposcopy, let alone a LETS or a cervical cone biopsy anywhere on that island. So I guess, you know, perhaps if she thought about that when she was planning her screening intervention, she might have used her time in terms of opportunity cost to screen for something that was much more potentially treatable. However, in the case of STIs, as we know, there is early intervention that makes a huge difference in terms of preventing congenital syphilis, preventing PID, which has impacts on fertility in later life. If you look at lung cancer versus cervical cancer, using those above, you can see a lung cancer cost probably wouldn't be a lot. It might just be an X-ray screen, for example. It's reasonably acceptable. There's certainly a lot of asymptomatics, people walking around with lung cancer early in their disease. So the answer to that question is yes, there is a reliable, safe screening test available. However, early intervention will not make a whole heap of difference, depending on what kind of lung cancer you have and how early it is, but as a general rule, that's true. If you look at cervical cancer though, the early intervention does make a huge difference because that's pre-cancer screening that you're implementing. So that bottom point, the early intervention exists that makes that early diagnosis possible, is the really important point about the screening programs. Okay, I think we've talked about this. So now we're going to embark on a little bit of screening test theory. So you will all be familiar with sensitivity, specificity, positive and negative predictive value. Now, I don't consider myself particularly bright, and so I struggled with this over a long period of time, actually trying to work out a way of remembering which was sensitivity and which was specificity. And I think, for me anyway, this is the best thing that works. If you have a look at these and talk about them in writing, so we'll go back, then I think this is, well, for me anyway, the important slide. If you're talking about sensitivity and you set up your grid correctly, then you should always have disease at the top and the test at the side. Then sensitivity is always going to be A over A plus C. And if you want to put that in words, which I think I do here, sensitivity is the proportion of positive tests in people who actually have the disease. So of all of those people with disease, that first column, how many of them have a positive test. So if you want to have a quick look, and we're going to do this in a second, at which test out of 2, for example, has a better sensitivity, that's the best way of doing it. And specificity is the opposite of that, and that is the proportion of negative tests in people who don't have the disease. So that's column 2, and looking at the bottom cell in that grid. These ones, positive predictive value, we won't go into. Okay. So I'm going to talk to you about the control program for Campbellonia, and we're going to do a pre-worked session where we look at sensitivity. So the 2 tests that you're going to look at are IncrediClam and Chlamydia. Now, if you just run your eye over that first column, as I was talking about in terms of sensitivity, I think it's pretty obvious which is going to be the best one. So we'll go through this, and this is without doing any calculations. So if you calculate A over A plus C, the sensitivity of this one is going to be 120 on 122, and that's a pretty high number. So that's a highly sensitive test. So if you're going to consider which of those tests you're going to implement, then if you have a look at the Chlamydia, and A over A plus C is going to be a fairly larger number, and that that sensitivity is not going to be as good as the IncrediClam. And here's a little something I prepared earlier. If you actually crunch those numbers, the sensitivity of the IncrediClam is 98, which isn't actually too bad. However, the sensitivity of the Chlamydia is 72. So that C value is really small with the IncrediClam, and therefore it's a better screening test, and that's the one you're going to go for. It's not just about the screening test. You also have to think about how many screenings are you going to do. Usually screening interval is really important to governments because that's going to determine how expensive your program is. If you do, in the UK, for example, cervical screening test is going to be every 5 years. Here, the old pap smear screening test was every 2. So as you can imagine, that's more than double the screening cost. The other important thing is how many people are you reaching? You can have the best test in the world, but if you're only getting 10% of your people actually going through that test, then you're not going to make an awful lot of difference because you won't know about the vast majority of people who have a positive test, so you can't do anything about it. Now, the other thing I'm just going to do is have a quick chat to you about point of care testing and why it is so good. So the definition of a point of care test is that it's a reasonably simple diagnostic test, kind of bedside. You can carry it out. You can carry it out in outreach, or you can carry it out in a clinic. And it's very close to the site of, or at the time of clinical care that you actually get the results. You don't need a lab, and it's undertaken by clinicians who aren't lab techs. So the result is available really quickly, and therefore it's able to influence the care straight away, which is provided to the patient. Its other names are bedside testing or near patient testing. So a urine dipstick, for example, would be something like that, or a urine pregnancy test. Now, what I want to do is just to demonstrate to you the difference between using a point of care test versus not. So this is looking at the time to treatment as it impacts the incidence of pelvic inflammatory disease. So this table represents the time to treatment down the left-hand side of the column. The first row being treatment within 0 to 7 days, the second treatment in 1 to 4 weeks, the third row being treatment between 1 to 12 months, and then the last one, which is obviously the worst outcome, no treatment at all. Now, if you have a think about, let's assume that 10,000 people get diagnosed with chlamydia or gonorrhea, and as I said, there are 80,000 cases a year in Australia. Based on the time to treatment proportion I mentioned in the last slide, this translates to 2,000 infections being treated within the first week, 3,000 in 1 to 4 weeks, 3,000 in 1 to 12 months, and then 2,000 won't receive any treatment. So we know that there is a proportion of people who develop PID as a result of delay in treatment. And that is around about 2 to 3% in 1 to 4 weeks, and then it's about 10% by a year. And so this is how many cases of PID this works out to be. And then the other thing is the likelihood of onward transmission due to delayed treatment. Now, if you focus on the orange cells, you can see that the potential benefit of a point of care test is that if you treat all the people at the time of consultation, it could potentially prevent over 500 cases of PID and therefore reduce the likelihood of transmission to hundreds of people. And this is why point of care testing is a real game changer in terms of what you want to implement in Campbellonia in terms of your SEI control strategy. Now, there was this fellow called Hugh, and he looked at doing some modelling to see what were the benefits of point of care testing. So he used the setting of a remote Aboriginal community where treatment was provided in about 75 to 89% of people who tested positive, and that the average time to treatment was 21 days. So the point of care tests used in this modelling had a sensitivity of 70% and also 95%. In other words, 95% of those with a true infection had a positive point of care test result. If you look at these two graphs now, the vertical axis shows the community prevalence of infection, and the horizontal line is the time in years since the point of care testing was implemented. The solid line is the default situation, so nothing changed, and the dotted line a point of care test with a sensitivity of 70%, and the broken line a point of care test with a sensitivity of 95%. So the graph on the left shows us what would happen in a community where the chlamydia or gonorrhea prevalence was 7%. After 5 years, if the health clinic in the community tested using a point of care test, with a sensitivity of 95%, the prevalence would be 0, and that's pretty powerful. If the test had a sensitivity of 70%, the prevalence of infection would be 2%. And if the clinic continued as the default, then the prevalence would be around 3 to 4%.
Sorry, Jackie, we just have a question come through. New South Wales Health asked, what's paradoxical about the point of care testing data?
The paradox really is that you can't, well, certainly I couldn't see why you would prevent all of the PID just with delay in treatment. So that's the only reason why it's paradoxical. Okay, and perhaps we could have a discussion. Terence, is there any way that we could have a discussion after this, or is it only...
Definitely. You won't be able to speak to them directly, but they'll be able to answer you in the chat box or the question box.
Okay, no worries. All right. Okay, so New South Wales Health, whoever you are, I hope that answers your question, but if it doesn't, then save it and we'll have a discussion in a second. So if you look, the graph on the right actually shows a community where the prevalence is a heap higher, about 13%. And if you think back to those figures that I showed you in the trials where Lewis looked at combining about 67 remote community prevalences, in Aboriginal people, Aboriginal women under 25, the prevalence was 22%. So 13 is actually reasonably moderate still. After 5 years of using the point of care test with a 95% sensitivity, the prevalence drops to 0.5%. And even using a test with the sensitivity of 70%, the prevalence still drops, really remarkably, I reckon, to 4% after only 5 years. So you can see that using a point of care test where you have a test and treat on the same day makes a huge difference, theoretically anyway, to the rate of disease. Okay, the other thing I guess that's important is the specificity. If the treatments treat and the side effects are pretty rare, then poor specificity, in other words, you've got a really sensitive test, but you're going to overcall it a lot and have a whole lot of false positives, might not be of great importance. However, if you're talking about STIs particularly, the fact that you're diagnosing people with STIs carries with it quite a lot of stigma and some consequences, particularly some grumpy phone calls and texts to partners, accusing them of all sorts of things that perhaps didn't have to happen. And the prevalence is also quite important because that does have a huge impact. And I'm just going to go through that now. So this flowchart just helps describe the interaction between the prevalence of infection and test specificity. So in this population with 1% prevalence of infection, we've had 1,000 tests taken. And so therefore in this population, we would expect 10 to be infected. In other words, they're the true positives. And we would expect 990 of them to be without infection. So they're the true negatives. If you focus on the 990 people without infection, a point of care test with 95% specificity would mean that 940 of the tests were negative, which is great, but 50 people would be told that they have an infection when they don't. And that is a bit of an issue. Let's have a look if there's a 10% prevalence. So again, 1,000 tests taken. So the only difference is the prevalence varying here. And in this population, we'd expect 100 to be infected. So they're the true positives. And 900 or 99% are truly negatives without infection. So if you focus on the 900 people without infection, a point of care test with, again, 95% specificity would mean that 855 of those tests were properly negative and 45 of them were actually false positives. In other words, 45 of them will be told that they have an infection when they don't. And another way of looking at it is when the point of care test was positive, 100 would be true and 45 would be false. So that still is fairly high. So, and I'm nearly finished now. How are you going to save the CEO in Campbellonia? Well, you're going to talk about the important components of what constitutes a robust STI control program. And the first obviously is education. So community and health staff, probably community is more important in my book because that's where you have the potential of people actually coming in and asking for tests. But equally important, I guess, is also that if you've got a clinic that's happy to accommodate that and will offer unasked to make sure that there's screening, then that's also a really good thing. You need an accessible service. You can just target on age-based risk because we do know that under 25 years, there are a lot of STIs. So that's one thing that's really good that you can give to the Campbellonia CEO to say, this is going to be an integral part of our STI control program. Based on what I've shown you, I'm hoping that you would talk quite a lot about point of care testing and how wonderful it is. And in fact, in our own service, we're just about to, I'm hoping in the next couple of weeks, we'll get a point of care testing machine. Now here in Cairns, we actually have results back in about 3 days. However, having a point of care test that's available the same day makes a really critical difference in terms of that speed of chasing and following up people. There are single dose treatments available, and so using a syndromic approach, you're actually going to try and make sure that if people require treatment and they get treated that day, you need to make sure that you do have condoms available in whatever ways that you can. And you also need to try and make sure the contact tracing, notification and treatment occurs. That's probably the hardest part. It's easy to offer antibiotics. It's not quite so easy to make sure that you do some partner notification. ASHM, the Australian Society for Sexual Health and Sexual Health Medicine, has a fantastic contact tracing manual, and that goes into quite a lot of the theory of contact tracing and partner notification, both upstream and downstream. So if you're at a loss for some good bedtime reading, then perhaps that would be something that you would like to think about. And I think the other thing, and this is very much influenced by STRIVE, the test looking at like implementing a high quality STI control program in the field, it's really important that you make sure that data gets back to clinic staff so they can see how they're going. And that's not only to give them a pat on the back if they're doing a great job in screening and testing and treating, but also to highlight gaps in service where perhaps they're not offering routinely in kids under 15, for example. And that obviously has a whole heap of issues attached to it as well, but it is certainly something that is important to consider and have a position on. So I guess the important thing for you would be to make sure that you tell the CEO that you're going to use some time to plan, and make sure that you include an evaluation. And I'm sure that all of you have a good framework, a robust one, to make sure that any program planning includes preemptively making sure that there are evaluation indicators embedded within that plan. You're going to select a suitable combination of strategies, and those will be predicated on making sure that you treat as soon as possible, ideally using point of care testing, implementing contact tracing education and condoms. In terms of population education, making sure that you do both staff and community, and that you do contact tracing effectively. In the vast majority of cases, contact tracing is delegated to health workers in my setting. So they're often the poorest paid, and they have the most thankless job. So they also get things like giving people large, painful syphilis IM injections. So being the bottom of the pecking order, I have an awful lot of sympathy for the great job that they do. Then you need to target at-risk groups. And as I said, age-based testing is a really nice way of doing that, because you're not targeting people because they look dodgy or you think they might have an STI just because of the way they walk into the room. You can just say to them, well, you're under 25, and that's our policy of making sure that we offer STI testing to anyone who is your age. And then this is the harder thing to do, is build clinic capacity with making sure that you have regularly audited quality systems. Okay, I think that was it. Has anyone got any questions?
So everyone, if you have any questions, please ask them now. There's also a chat function you can use to have a discussion. Dr. Meehan, you're also able to access that chat function. It's at the bottom of the screen.
Yeah, I've got it open now. Everyone's got a particular question. I guess while people are thinking, or perhaps rousing themselves from the post-lunch stupor, one of the things we did talk about was the difference between prevalence and incidence. I guess the thing about incidence is that you usually use those for acute infections, for example, or acute conditions. So because STIs are very much treatable diseases, you would think that you would talk about them in terms of incidence, and that's certainly reasonable. But given STIs with a long time frame, for example, HIV, that's where prevalence can be really useful. And also, unfortunately, particularly in more remote places, when you're talking about rates that haven't fallen and are still increasing, in fact, over the last couple of decades, then as I said to you all previously, that is one area where I think the use of the word prevalence, although you wouldn't usually do that with acute infections that are treatable, like chlamydia and gonorrhea, for example, but there is certainly a case for using that if you wanted to get into the public health semantics of how you use words.
So in the Q&A box, Dr. Meehan, there's 2 questions there for you to answer.
Oh, okay. Or maybe I'm not looking in the right place.
I can announce them for you to make it easier.
Okay.
So New South Wales Health has asked, could you comment on the use of ZAP packs with increasing gono resistance patterns? Are they still useful?
Yep, that's a very good question. As I said in my presentation, the issue about using azithromycin, amoxicillin and probenecid is that if you look at the national guidelines now for treatment of gonorrhea in particular, then that's not a good thing to use. You have to use ceftriaxone. More worryingly, there is now ceftriaxone resistance in gonorrhea, particularly from Southeast Asia. That's hovering around about the 4 to 4.5% is my understanding the last time I looked, although the last time I looked was probably a year ago. So that's an issue because, and ASHM now recommend that you give ceftriaxone, but you also give azithromycin. That has the added benefit of making sure that you also treat any unlooked for chlamydia, because as I said, they often will travel together. In terms of Zac packs, it's my understanding that they're still used in remote northwest Kimberley, but I don't think that they're recommended anywhere else in Australia at this point.
Someone else has also asked, can different parameters be put into the equation, and can you provide the reference for it?
What are we talking here? The equation for, oh, you mean the prevalence of the Anderson and May equation?
I'm not too sure. That's all the information the
Okay.
person's provided.
Yes or no in the chat box, please.
Yes.
Yeah, okay. So yeah, the Anderson and May is really, as I said, it assumes equal mixing, which we know is not correct with STIs, that people will, as I said, have sex within their own kind of groups. And it also assumes populations where there is no influx and efflux. So basically, it's a way of thinking about strategies for control where it's useful. So yes, be my guest, you can put in all sorts of other different things into that equation. The equal sign, in my personal view, is a bit misleading, because it kind of looks like if you line up all your ducks correctly, then you could probably decrease the prevalence. And we do know, just given that it's an equation that is used for modelling only, and we know that the two kind of rules for using that modelling already are not applicable in practical situations, then I don't think that it's something that you should say, righto, well, I've done those three and that's the end of my STI control program. Definitely not. If you can think of other things, I'll be very keen to hear them.
Thank you. So New South Wales Health has just asked if you could speak a little bit louder. Also, in regards to your slides, I believe you will be sending your slides through and they will be able to be accessed by people.
Yeah,
is that correct? Yep.
Very happy to share them.
Yep. And then we have another question. Could you comment on POCT versus urethral swab in microscopy for symptomatic male patients presenting with discharge or dysuria or other urethritis symptoms? Would you recommend continuing microscopy for these patients if facilities are available, or moving to a POCT only system?
One of the things we didn't really touch on was, and I'm really yelling now, so I hope you can still hear me okay. One of the things that we haven't touched on is the PCR test mostly does not give you a resistance pattern, and that is a bit of an issue. So there is some discussions in some sexual health sentinel sites that you can, we can make sure that there is still some swabs taken for culture. There is not a lot of yield in someone who's asymptomatic, so it would really only be people with pussy discharges that you would send for culture. There's also an argument that if you're sitting in a remote place and you know that it's Friday afternoon and you're not going to get that swab off before 3 days, there's no point in sending it because the gonorrhea will not grow. There is now a resistance gene that is can be checked for with PCR. That's newer technology that's coming out from the University of Queensland, but I don't think that's out of testing yet. It's certainly not in universal use. In terms of whether you implement a point of care test, then the sentinel, kind of sensitivity patterns aside, the important thing that you could do with that is that it means that regardless of whether you use a urine or a swab, and in fact, the point of care tests are all done on urine or blood at the moment, the ones that are currently available, and the point of care tests that are available for gonorrhea and chlamydia are urine tests. So in terms of acceptability, they are fine. Whether you actually do microscopy or not, the point of care tests are incredibly sensitive, and that also makes them just God's gift to STI control programs. And that's why throughout most of Australia now. And I would love to say through the world, but that's not the case, unfortunately. We do lead the world in terms of making sure that we have robust and very highly sensitive and acceptable screening tests. So I guess what I'm saying is, you know, we really should be able to make an impact on that prevalence, but in some populations, we haven't seen it as well as it perhaps could be. And I think point of care tests might make a difference there if it's implemented through most of Australia. I hope that answers your question.
Apologies for the mispronunciation. Does anyone else have any questions? So someone else has asked, once you receive your POCT machine, how frequently will you screen at-risk groups?
That's a very interesting question. So we have, the Strive data suggested that it's really the people who are under 25 who are at risk. However, because we can and because we actually have it on site, we've actually extended that up to age 39 to routinely offer people testing. In terms of how frequently we would screen, for an at-risk population, the current guidelines in most of Australia, and that includes this here, it still says that you screen people who are at risk annually. I think personally there is a case to be made for screening the at-risk under 25s every 6 months. And the WA guidelines, which are the Silver Book, actually advocate that in high prevalence or high risk populations as well. If you look at what constitutes a high risk population, they are people who are under 25, people who have had contact with the justice system, people who have had more than 3 partners in the last 6 months. You can probably add to that list. Most people will kind of recognise that, I think, on a sexual history if they meet it.
Thank you, everyone. I believe that concludes today's webinar. A big thank you for Dr. Jackie Meehan for having such a great presentation.
Thanks, guys, and good luck with your exams.